All right. Hello, everyone. I'm Himabindu, and welcome to the New York chapter of the ACC's first Aftershocks webinar of 2023. So these sessions provide bite-sized recaps of high-impact lectures from prominent cardiology conferences, such as those hosted by the ACC, HFSA, AHA, and more. And this presentation will also be available on the New York ACC's YouTube channel. And tonight, it's my distinct pleasure and honor to introduce Dr. Nir Uriel, who is the director of the NewYork-Presbyterian Heart Failure, Cardiac Transplantation, and Mechanical Circulatory Support Programs at Columbia University Medical Center. He is the national co-PI for the Momentum 3 and the ARIES studies. And before we get to his presentation, just a few housekeeping items. If you have any questions, we will be having a Q&A session following the presentation. Please feel free to enter your questions into either the Q&A or the chat boxes. Thank you, Dr. Uriel, for your time tonight, and we're looking forward to your presentation.
Thank you very, very much, Ima. It's a great honor to be here with all of you tonight and to share some of the key to success and lesson learned from Momentum 3, focusing on the 5 years outcome. I think I'm actually very excited to open the year and speaking about this topic to you guys, because I found it one of the most important discussion items that we'll have on advanced heart failure in the coming year. If we can go to the next slide. Those are my disclosure, nothing relevant to mechanical circulatory support. Next slide, please. And this is what we're going to discuss a little bit together. The HeartMate 3 5-year data, the risk score, a little bit about a couple of other things that make this data so good, and this is the aortic regurgitation, ICD, and some way that maybe we can do it even better, some center variability. So next slide, please. Without saying, the HeartMate 3 is a pump that most of you are familiar with. It's a completely magnetic levitated pump that is designed and engineered to minimize the obstruction of red blood cells and thrombosis. Next. It has 3 unique features. Have a wide blood flow passage to reduce the shear stress. It's frictionless with absence of mechanical bearing, and it has an intrinsic pulse that's designed to reduce the studies and avert thrombosis. Next slide, please. The Momentum 3 study was the biggest LVAD study conducted up to date. The original study, the pivotal study, was designed to be 1,028 patients. However, the study continued to enroll in the continued access, and we'll see that it's important to remember the main result of the study. The study has a composite endpoint that is survival, free of disabling stroke, and free of the need for device exchange. And as you can see in this slide, 74.7% of the HeartMate 3 patients reached this outcome. Again, survival, free of disabling stroke, and free of the need for device exchange. The HeartMate 2, that was the control arm in this study, reached excellent outcome by itself, but it was only 60%. Of course, demonstrates superiority of the HeartMate 3 over the HeartMate 2. Next slide. It is important to emphasize that in the 2-year survival time, and now we're talking only about survival, there were no difference between the HeartMate 2 and the HeartMate 3. Each one of them reached almost 80%, 79% with the HeartMate 3 and 76.7% with the HeartMate 2. Next slide. So of course, it was important to understand what's happening after. We already have a pump that we know that is so successful. So what can we learn more? So just to give some cap on the timeline, the Momentum 3 study started the pivotal trial in the end of 2014. The pivotal trial finished in enrollment in 2016 and finished the follow-up in 2018. However, the decision to move to a 5-year study and to collect the data got approved only in the beginning of 2019, and the enrollment to the 5 years in middle of 2019, in a way that we finished the 5 years outcome only in mid-2021. So the 5-year extended study was an observation follow-up study, so the following the 2-year completion as a condition for approval to destination therapy. This is a separate protocol from the original study. It's a it's a post-approval extended phase study and was developed and approved by the FDA. But as you can see, there is a time gap, and we'll go to it in the next future, in the next few slides. Next slide, please. So what was the objective? First of all, to see on the composite endpoint that I just presented to you, is it still remain the same at 5 years? Is the survival free of disabling stroke and free of the need for device exchange is still higher with the HeartMate-free compared to the HeartMate-T at 5 years? Next thing is maybe now we can see some difference in survival. So as I showed you, there was no survival difference in 2 years. What happened after 5? And number 3, next slide, please, is to see whether or not there is reduction in serious adverse events such as device thrombosis, stroke, bleeding with the centrifugal flow pump on the long run. So first, let's reacquaint it by the study itself. Next slide. This is the slide that demonstrates what is the study diagram. As you can see here, the study was 1-to-1 randomization, 516 patients with HeartMate-free and 512 with HeartMate-2. Eventually, the 2-year study, we finished with 287 HeartMate-free patients and 247 HeartMate-2. Next slide. Following another 3 years, there was 141 patients finishing the study with the HeartMate-free compared to 85 patients with the HeartMate-2. As you can immediately see, there was a difference in the amount of patients that lost the study. There was 58 cases of death in the HeartMate-free and 81 with the HeartMate-2. There was 37 patients that got transplant with the HeartMate-free compared to 29. Next slide. The patient population are also very important to remind ourselves. This is a very, very sick patient population. As you can see, more than 78% of the patient in the study was destination therapy or bridge to candidacy. Only 20 to 23% of the patients were bridged to transplantation. So this is de facto a destination therapy study. Second, the majority of the patients in the study was Intermax 1, 2, and 3, 85% in both arms, as you can see here. And because of that, the medication was actually very low rate of ACE inhibitor and low rate of beta blocker because those patients were extremely sick. So let's go and jump directly to the main result of the study. And as you can see here, the main result, next slide, demonstrate superiority in survival. And this time we started immediately with survival. There is 58.4% of the HeartMate-free patients survive to 5 years compared to 43.7% of the HeartMate-2. This is a hazard ratio of 0.72 with a p-value of 0.03. And there is completeness of the data in relate to the survival analysis, meaning this difference that we see of almost 30% is valid, and the difference that we didn't find in 2 years, as you can see in the 2 years mark, actually open up over time, and this is a significant improvement. Next slide. If we look only the destination therapy, we also can see a difference in the survival, 54.8% compared to 39.4%. But what is more important is to emphasize, regardless how we dice and cut the data, there is more than 50% survival of 5 years. This is the first time we demonstrate such an outcome with mechanical circulatory supports. Next slide. So why is this outcome? And as you can see, there is similar rate of death from heart failure or infection or other causes between the HeartMate-2 and HeartMate-3. But the cause of death was completely different in relation to hemocompatibility related adverse events, i.e. device thrombosis, stroke, and bleeding. This was all the promise of the HeartMate-3, and it seems to be that it demonstrates this promise to us. So let's look now at how the composite endpoint that we did with the momentum-free look like. And this is the next slide. Next slide. Thank you. So this is the composite endpoint that demonstrates 54% of the patient with the HeartMate-free was alive without disabling stroke and without the need for device exchange after 5 years, compared to only 29.7%. I want to emphasize that there is some missing data in relate to the adverse event that not exist. Those missing data are not exist with the survival, and this is due to the gap in time that I demonstrated in the beginning. However, this is give us a glimpse because the data gap exists in both pumps, and we definitely see a significant improvement with the HeartMate 3 compared to the HeartMate 2. So let's see and break those adverse events a little bit into more detail and go into it with the next slide. As you can see here, there was a significant reduce in the any bleeding, GI bleeding, any stroke, and of course, suspected or confirmed pump thrombosis between the HeartMate 3 and the HeartMate 2. Furthermore, it seems to be that the HeartMate 3 was associated with significant lower rate of arrhythmia, 0.2 event per patient year compared to 0.283 event per patient year. Again, it's important to emphasize there is some gap in data here. However, those differences and gaps in data exist with both HeartMate 2 and HeartMate 3. So if we conclude, and next slide, the result of the momentum 3, next slide again, next slide, of the momentum 3, we definitely can see that in this 5-year follow-up study of patients from momentum 3 IDE study, we demonstrate that the fully magnetic levitated HeartMate 3 was associated with better composite outcome and higher likelihood of overall survival at 5 years versus the Axial-Flow pump. Next slide. Those findings that median survival of HeartMate 3 exceed 5 years, even in those patients with refractory heart failure ineligible to transplantation, i.e. destination therapy, should spare effort to increase access to such therapy. So now that we know that we have a great pump, can we predict who is going to do better? Next slide. So what I want to share with you is another paper that we just published actually about the development of a risk score to predict. This came out in JACC a few weeks back. Next slide. As you can see here, we took actually not only the pivotal study that I show you now, the 5-year data, we actually took also the continued access protocol, the SCAl. And we had altogether 2,200 patients. We derived the risk score from 70% of the cohort, 1,540 patients, and we validated it on 30% of the cohort, 660 patients. Next slide. And eventually we look at all the parameters from demographic like sex, age, race, BMI, heart failure etiology, etc., to medical history, baseline lab and imaging, baseline hemodynamics, all the parameters that we can imagine. Next slide. And what we show that there was 6 parameters that found to be important. One is age. Second is prior valve procedure or CABG, meaning sternotomy. Third is sodium. Fourth is BUN. Fifth is LV-EDD less than 5.5 centimeter. And right atrial pressure divided to pulmonary capillary pressure that was more than 0.6. All of them seems to be associated with a risk to adverse outcome. It's easy to remember there is 2 parameters that are actually demographic, like the age and the CABG and the valve. 2 parameters that are lab, like sodium and BUN. 1 parameter that is echo, less than 5.5, and 1 parameter that is the right heart pressure to the wedge pressure. Next slide. As we can see here, divided those patients into 3 groups based on the HeartMate 3 risk score, can easily identify 3 separate territories. One that carry very, very good outcome of 92% in 2 years survival, patient with low risk score of less than 2.4. The other very high risk, like the patient with risk score about 2.97, that was 69% 2 years survival. And the middle. Each territory actually increased the risk by 2-fold. So this risk score really can give us a good glimpse about what is the patient. So, next slide. I made it something very easy for you. There is an app that you can go on the website, and if you put now your phone in front of the camera, you will see that this QR code is real, and you can actually link to the HeartMate 3 risk score dataset. And when you link this HeartMate 3 risk score to the dataset, you will get the questionnaire that you put here. Very simple. Age, history of CABG or valve, sodium BUN, right atrial pressure and wedge pressure, and whether the LV is below 5.5. When you fill this up, you immediately can get what is your patient 2-year survival risk score. So take this QR code, and that will link you directly to this. So we demonstrate that there is good outcome. We know how to predict the outcome, but why there is better outcome? Next slide. So number one that I want to show you is something that we just published now in the European Heart Journal, is the incidence of aortic regurgitation that we know that on the long run can limit the ability of the LVAD to support the patient. Next slide. What we learned from momentum free is that the rate of significant aortic regurgitation is half with HeartMate 3 compared to HeartMate 2. As you can see here, in 24 months, it's 7.2% in the HeartMate 2 compared to 3.7. Next slide. And if we look at the accumulated or cumulative significant AR incidence, it's 5.6% with the HeartMate 3 compared to 11.5%. Really exactly half the rate. Next slide. We want to learn who are the patients who will develop this AI with the HeartMate 3, and we can still see that the same risk factor exists. It's patients that are older, it's women. We didn't have the aortic valve opening data in this data set, but this would have been very interesting to learn whether this remains one of the key factors associated with aortic regurgitation. Next slide. So if we summarize what we learn about aortic regurgitation, that is to remind you, a problematic because it can cause a recirculation syndrome leading to reduced LVAD effectiveness with increased retrograde blood flow into the ascending aorta, decreased LV unloading, increased end-diastolic filling pressure, mitral regurgitation, RV after and RV failure. We learned that both in the pivotal study and in the CAP, the rates are half. The CAF and the pivotal were very similar. And we also learned that female sex and age remain a significant risk factor for patients with AI. What else we learned from momentum free that is important for us to remember? Next slide. And it's important to remember how the HeartMate 3 interact with other devices, specifically ICD and CRTD. This is a study that actually Dr. Vidula and myself was doing together. It's under review right now, and we can look a little bit about this result. In order to do so, we took, next slide, 1,500 patients from the CAP and the momentum free. And we try to understand how this affects each one of them separately. So we look patients that have HeartMate 3 only, that was only 150 patients. And we look at patients that have HeartMate 3 plus ICD or CRTD, another 1,200 patients. And we had multiple comparisons done, as you can see, to follow. In order to make sure that the ICD and CRTD was put it correctly, all the X-ray from all those patients were reread by the investigator in order to make a clear data set that will not have any question thereafter. Next slide. As you can see, if we compare to HeartMate 3 with ICD or CRTD to HeartMate 3 only, meaning is the fibrillator importance, there was no difference in survival at 2 years between the two groups, meaning that we did not see any benefit in this cohort of survival between ICD and no ICD in HeartMate 3 patient. Next slide. If we try to understand in a ventricular arrhythmia and readmission rate was different between those matched patients, we learned that there was some differences. If we compare HeartMate 3 plus ICD or CRTD to HeartMate 3 alone, we can see that there was a significant difference in the rate of ventricular arrhythmia, 0.19 to 0.09. The rate actually of readmission, 2.19 to 1.84, was pretty similar. However, if we compare HeartMate 3 with CRTD versus HeartMate 3 alone, we can also see a difference in the readmission rate, that the CRTD arm had more readmission compared to HeartMate 3 without CRTD. Next slide. It's important then to emphasize With the CRTD, we didn't know whether those devices are active, whether they are biventricular patient, whether they are ICD or alone. However, from what we can summarize, that survival is 2 years is identified between HeartMate-3 alone, HeartMate-3 for ICD, and HeartMate-3 and CRTD. Hospital admission seems to be similar between the three, and ventricular arrhythmia seems to be lower in HeartMate-3 alone patient. This is in a matched patient cohort. This is putting an end to all the debates whether or not we need ICD or we don't need ICD, and we need to remember there is other parameters that are important to say that. So just before I'm finishing, I want to emphasize one point. It's not only important what the pump is doing and what are we setting the ICD and whether or not we develop AI. It's actually important what we are doing. And the next slide I want to go, please go to the next slide, is speaking about how we are different among each other. And we call this study a center variability that we published it almost 6 months ago. Next slide, please. And what we took here, we took all the sites that implanted significant amount of HeartMate-3, meaning more than 15, and this was 48 sites. So those are big sites. And we look at their outcome early in the first 30 days, between 30 days and 2 years, and we try to divide those outcomes into the top 25 percentile in green or the lowest 75 percentile, meaning bad outcome, in red. And of course, the middle will be black. And to understand how this outcome actually correlate with the center variability. Next slide. So first of all, we learned that the center that perform well have a different patient population. They were younger, 57 compared to 61, a little bit less male sex, 73 compared to 84. Caucasian race was lower rate, 58 compared to 83. And it seems to be that prior valve correction or coronary artery bypass was lower, 15% compared to 29. And the rest of the difference was in the severity of the illness. Intermax 102 was only 16.4% in the sites that were doing better compared to 47, and the intra-aortic balloon pump rate was 6.8 compared to 19.5. Next slide. But it's not only the patient were different. What we did with them was different. As you can see in the good sites, the top 25 percentile, we actually did not do too many procedures. Only 21% received concomitant procedure to the LVAD compared to 48.7. And this is aortic valve, tricuspid, mitral, etc. Next slide. It's important to emphasize this slide is really shocking. There were sites, as you can see in the first 30 days on the left, that have a 0% mortality, no death. And there were sites that in the first 90 days already had 25% mortality. At 2 years, those differences continue. And there were sites that in 2 years have only 2 to 3% mortality. And there are sites that reach 40% mortality. So sites matter. It's important that we'll know what we need to do and what we don't need to do. Next slide, please. It's important to emphasize it's not only the survival. Those differences were identified on each one of the adverse events in each time point, early and late. As you can see on the left is the early. GI bleeding can range between 0 to 30%. Stroke can present between 0 and 20%. And sepsis or driver infections, there was cited already in the first 90 days, 20% of them, of the patients they implanted were actually with driver infection. Similar to those differences continue in 2 years. Next slide. So how can we look at it? And we can create a heat map and see that there are sites that are mostly green, and there are sites that are mostly red, and there are sites in the middle. But it's really look like it's in cluster. There are sites that have good practices and sites that have bad practices, the red one. Next slide. So how our site is doing? Our site is doing well, and to link all of it together, this is the data from Columbia University, a 5 years outcome. We have 280 HeartMate-3 patients. Our 5-year survival right now is 67.6%, actually improving as then compared to the momentum-free. So definitely, we want to see our sites actually that have a good outcome continue and take it. But even without our site and site-specific, next slide, it's important to remember the momentum-free result. 5-year survival of 58.4% in 80% of the patients that are not eligible to transplantation, in average age that is 10 years above the average age of transplantation. This is unbelievable, and this is time to utilize that technology. So thank you very, very much, and I will be happy to answer any question, and you can go to the next slide and actually close the presentation. Thank you.
Thank you, Dr. Uriel, for a very interesting presentation, and you really went beyond the topic and touched on some really hot areas. So we have a few questions in the chat box, but first I wanted to ask you, you've shown some very compelling 5-year survival data. And in the current age, we know that patients who receive an LVAD have longer wait times to transplant. So how do you counsel your patients, particularly your younger patients, who may be considering LVAD and then later bridge to transplant, or perhaps directly proceeding to transplant?
Thank you, Ima. This is a phenomenal question. And actually, I will divide my answer to maybe 3 or 4 groups of patients. I think every patient is a little bit different. If I have a very young patient in the 20s, I actually don't know what is better. Is it better to go to an LVAD, buy this patient 5-10 years on an LVAD, and then eventually start the clock on a transplant, or to really start the clock on a transplant when he's 20 years old? In a best case scenario, we'll live to the 50. Who want to die in the 50? People want to live forever, but at least to the 70 or 80. And I do think that this debate about the young patient population exists. I'm actually presenting both approaches to the patient. I tell him that we can put the LVAD now. He can have a good quality of life, excellent quality of life. We didn't go to it, with a good chance to have a survival. And down the road, after 5-10 years, we can reconsider and consider transplant and move to that. I don't think this is a bad advice to give him. There is the extreme other side of the patient population, patients that are above the age of 65 and patients that have other significant comorbidity. We, in our program, for example, doesn't have an age limit. So we can transplant people in the age of 73, 74, and 75, but we do a much more due diligence about those patient population. But we really need to do a fair discussion with those patients. As I said, a patient about the age of 65 and a patient with significant comorbidity, it's important to emphasize that there is a balance. They can get the surgery immediately, not wait in the hospital, become more disabled and more sick, and get probably an excellent 5-year survival and even more with minimal comorbidity, as we saw with the heart meat free. Or we can stay in the hospital. As you said also, Ima, the wait time in general in transplant right now is much longer. And unless the patient is status 1 or 2, the chance of transplantation is extremely low. And in status 2, to remind you, those patients are waiting in the hospital with a balloon pump or with Impella and can get extremely sick and debilitated. I actually really think it's time to do a study similar to the roadmap study that really evaluate those patient population, because for me, I feel that sometimes we are risking too much, and I will use a tough word in saying you're playing a little bit Russian roulette with those patients that we put in the hospital and waiting instead of giving them an LVAD. Let's start their life. It's going to be a good quality of life. When we speak about comparing the 5 years outcome between transplant and LVAD, we need to be cautious. The mean age in any kind of study in the transplant population is young in almost 12 years in the average age in the LVAD population study. 12 years is a lot of time to change completely the outcome. The majority of those patients were patients that are not eligible to transplantation, meaning they are sicker. So to have a 58%, almost 60%, 5-year survival with patients that are not eligible is unbelievable. The group in the middle, this is the big challenge. The group in the middle is the group that sometimes you can say transplant may be superior. They are 50 years old, maybe superior right now to the data that we know. But I want to throw a couple of other elements that I take into my consideration. Whether this patient have the ability to take immunosuppression without a problem, i.e. if a patient that just recovered from cancer, another element. We know that there is a new consensus document, but we also know that cancer is just a step away after immunosuppression is being initiated in a cancer survival, and we just published about it in Circulation Heart Failure. So I do think a lot of things come, and the most important is to explain to the patient. Sit in front of him and tell him, you're not choosing a worse option. It's two different options that are great, that are going to offer him a great outcome and a great quality of life, him or her. And I do believe that with the right counseling, eventually the patient will choose the right thing for them. And again, there is no right and wrong in this field.
No, thank you, Nir. That was a wonderful answer. And I think what you said at the end there is very important about presenting both options to the patient together. And, you know, I tell my team that to think of LVAD and transplant as the right and left sides of the ventricle. You know, they both are codependent, and you really just need to pick the right therapy at the right time for each patient. And that might change as the patient's clinical status changes.
And Ima, you use a very important word now that you and I actually lately we like to use is time. We need to remember, time is what we're talking about here. Those patients doesn't have time. It's important to get to advanced heart failure, but those patients also have limited time thereafter. So when you have limited time, and time is so important, sometimes it's better to start life earlier rather than live in a limbo. So I think all of this have to take into those considerations.
No, thank you, Nir. We have some questions from the audience. So one of our first questions is regarding the risk score. So how do you use this in your clinical practice? Do you use this during your selection meetings, for example?
So great. So we use it during the selection meeting. We said what is the risk score of the patient. However, we need to remember, let's say the patient have the risk score, the lowest end of the risk score is at very high risk, and his 2 years survival is 68%, as I just show in our data. Does it mean that he is not going to be implanted? 68% is more than probably the 2 years survival without it. It probably is in the 8%. And we need to be very cautious about it. It gives out perspective, give us some understanding about the risk. It gives us the opportunity to discuss honestly with the patient, with the family, the gravity of his condition or her condition, and what actually we are going to offer him. So yes, I think it's important to emphasize that people understand it's not something that will say, oh no, we're taking only low risk patient. We'll take the high risk, but we will have this open discussion with the family of the patient, with the patient himself or herself, and make sure that they're aware of it. So that's the reason I gave the QR code. I think it's very easy. It's take Hima, seriously, it's take 2 minutes, not 2 minutes, it's taken 30 seconds to get this. And it's very nice to have this in the part of the selection meeting.
Absolutely. And, you know, you raised an important point about talking to patients about the risks and, you know, laying the expectations up front. How does your institution involve palliative care? Do you use it routinely for all patients, or, you know, how does your institution?
Yeah, we are very fortunate to use palliative care as a routine part of the discussion in the evaluation and thereafter. I think it's important to emphasize heart failure is a deadly disease without a therapy, advanced heart failure. It's more deadly than any other cancer. And while it's so deadly, we need to be honest with the patient and say, we can change it. We have now a therapy that can offer you 60% 5-year survival on all comer. If we do it conditional on the patient, we may have 80 and we have a little bit lower. But if we want, the patient have the right to say, you know what, I want to live a different life. We're not supposed to be upset with our patient. We're actually supposed to respect the choices that they do in life. Our role as provider is to advise, to educate, and to be there when the decision being made. We should not be pointing fingers after, oh, I told you, you should have done this and this. we are there as part of the journey of the patient through the advanced heart failure and the heart failure disease in general. And I think we need to remember that each one of us have different goals in life and different values in life and different way that we perceive what is quality life. So I think the palliative care is a crucial part of the evaluation process. It's need to be discussed, and people should not be afraid. It's not going to push patient to one way or the other. It's just going to bring them to a better understanding about the overall conditions they're living in.
No, thank you. That is very important. So our next question is about aortic regurgitation and particularly your approach to evaluating it and intervening on it. And, whenever I think about hemodynamics, Nir, I always think of you as kind of the father of the RAMP study, because your Columbia RAMP study came out when I had started my cardiology fellowship. So
Wow.
Maybe you can comment a little bit about your current perspective on RAMP studies.
Wonderful. So let's divide the AI to two. What I focus here is the intervention of the aortic regurgitation following the novo aortic regurgitation following the LVAD implantation. Actually, I see this part of it's a crucial part of the evaluation of a patient. As I emphasize in the recirculation syndrome that increase filling pressure, decrease the cardiac output, decrease the ability of the LVAD to support. It's important to know it can happen and we need to test it. So as part of our routine post-LVAD echo evaluation, we need to remember that the echo that is being done on the aortic valve is inaccurate. And in order to assess better aortic regurgitation, we need to do echo on the outflow cannula that can give us better understanding about the regurgitant fraction. Of course, the gold standard, as you mentioned, is the hemodynamic itself. And we have an hemodynamic protocol that we do 1 to 3 months post-implant and yearly thereafter if there is a need. However, I do think it's important to emphasize when you assess aortic insufficiency, just remind the technician and the reader, please do outflow cannula, PW, CW. Let's see the diastolic accelerating time, and let's see the S to D ratio in order to understand better whether or not there is an AI. If AI is being fine in a significant level, it's again important now to go to the hemodynamic. We don't want to wait until the AI will have some significant RV failure. We want to ask ourselves whether or not we want to intervene earlier. The first level of intervention, of course, is medical. And in medical, I'm looking at two elements. One is afterload reduction, utilization of medical therapy, and the other is speed adjustment to overcome the speed associated with the HeartMate 3. Again, we know that it's less common with HeartMate 3, but it still can happen. So it's very important to be aggressive, reduce the afterload, make the LVAD more efficient, and reduce the load. Second is, as I said, speed adjustment. I didn't mention here, but I said this is a gap in our knowledge in momentum 3. We don't have aortic valve opening. But from previous study, we know that aortic valve opening is crucial to the development of AI. So we need to try to find a speed in which the aortic valve is intermittently open in order to reduce the rate of development or progression of AI. And I, of course, going to comment about the ramp in general in a few minutes.
There's another question about your thoughts about the difference in the incidence of right heart failure in HeartMate 3 versus HeartMate 2, and perhaps the best approach to that to avoid chronic right heart failure in this population.
Yeah, and perfect point. LVAD, as the name said, it's left ventricular assist device. And the trouble starts when right ventricular assist device happening, or right ventricular failure happening. As I show in the 5 years data, the rate of heart failure was identical between the groups in relate to how much RV failure or heart failure, that is mostly RV failure, is how much RV. Okay, Elaine, if we can ask you to mute your line.
Katerina, are you able to mute?
Thank you. So the rate of RV failure, and we can divide it into two elements. One, in the perioperative course, and after that, what we call chronic RV failure or late RV failure. In the perioperative course, the rate of RV failure was pretty similar. It did not reach significant statistical. There was 2% difference between the HeartMate 3 and the HeartMate 2, but without statistical significance. In the late phase, as I demonstrate, there was no difference. We're talking about 8% in the late RV failure. It's important to know that we should and can treat patients. LVAD patients are still heart failure patients. They should get medical therapy. And we have a good medical therapy today that can reduce the afterload, reduce PA, making sure that the RV can work more properly. In a patient that are really still struggling with the RV, sometimes we go very old school and beside a traditional foundation therapy to heart failure, we add digoxin, for example, or other element to the therapy. But RV failure is something that we need to try to avoid. Hemodynamic optimization, and here the ramp test that you mentioned is so important. By the way, we are right now conducting a study. We already enrolled more than 50% into it. It's called Ramp It Up 3, in which the speed optimization is being done utilizing a full hemodynamic ramp test during the implantation of a CardioMEM device to understand actually the gap that exists between the PA diastolic and the wedge that is so crucial. And then the adjustment of the speed is based on the CardioMEM alone, knowing that this patient have a fingerprint with this type of a gap, diastolic gap between the PA diastolic and the wedge. I do think this is the way to try to fight RV failure, adjusting the right speed, giving afterload reduction. If necessary, diuretics in the right amount together with digoxin and other elements can help us manage those patients. And to all of us, we know the majority of the patient can survive with LVAD alone for a long period of time without the signs of RV failure.
No, thank you, Nir, for that wonderful answer and for really sharing, your clinical tidbits and pointers. We're almost running out of time, but before we adjourn, Nir, if you wanted to share some final thoughts, and perhaps also we have a number of fellows and junior faculty who are on the call, just some advice from your perspective for them for the new year.
I think that, first of all, and there is a lot of great question about the GI bleeding rate. It seems to be lower with the HeartMate 3 compared to the HeartMate 2 and other elements. I will say, medicine have a pendulum. We use a medication, we stop using medication. We use an LVAD and we stop using LVAD. There was a big change in the utilization of LVAD following the allocation system change in 2018. HEMA from exactly the same reason. We need to be very careful about what we are doing. And what do I mean? I do think we have a great therapy, a therapy that saves patient life, a therapy that gives 60% of the patient implanted with it a chance to survive 5 years. A therapy that is being tested on patients that are not eligible to the gold standard that is counter-cell transplantation. There is place for both, and there is enough patient for both. And we need to be very careful to suddenly change the pendulum from one direction to the other without understanding that there is a need to continue and develop. If I remember, the first mobile phone that I have was a very big Motorola phone. That's big, it's so heavy. If nobody would have bought that, we will not have the smartphone that we have today. There is a development that comes with utilization. If there is no utilization, there is no development. So we need to make sure that we are parallel this technology that are evolving. The transplant that is, I'm a big fan of transplantation. I will continue to be a big fan of transplantation and continue to push it. Together with LVAD, that I'm a big fan of LVAD and making sure that it. But we need to be careful not to suddenly switch ourselves to a word that is pending one to the other. There is patient that need both, and there is patient that can use both. There's patient that one will be better than the other. It's our responsibility to keep both fields alive and both fields in grow. This is what brings us to where we are today. LVAD started very early in the 60s when actually the first mechanical circulatory support successfully was implanted by the Beck in 1968 and transplant in 1967. But both of them develop in parallel because we understand that there is a need for both therapies. So I think it's important to continue and evolving and see where eventually technology will be pushing us to smaller LVAD, completely implantable, side by side, but maybe xenotransplantation without immunosuppression. All can be a little. But remember, never be only one side, be always in the middle.
That's a wonderful advice. And, thank you again for a very thought-provoking lecture and discussion. We're very honored to host you. And thank you everyone for joining us tonight. And we look forward to seeing you at our future events.